Good morning. It's a great pleasure to be here with you. It's a webinar about the HTLV, a silent threat, and its neurological manifestations. It's a webinar organized by Fiocruz, the Foundation Oswaldo Cruz, and the Global Health Network at the University of Oxford. It's a great pleasure to be here talking to you, and I wanted to congratulate this initiative. The HTLV is an old and ancient virus from the human species, much older than, except HTLV 3 and 4 recently described, but related to HTLV 1 and 2, it's much older. And maybe, if not the most neglected infection, one of the most neglected infections for sure in the history of humanity, especially because of the complexity, the conceptual complexity of the subject. The Professor Steve Jacobs is going to talk about 100,000 years of our culture. It does that the mechanism in its pathological form, clinical form, creates a very particular complexities in comparison to other virus diseases or phylogenesis that is more advanced. And it makes it harder for diagnosis, for spectrum of symptoms, and consequently therapeutic protocols. We'll have the great pleasure to count with professionals that are most highlighted professionals, such as Steve Jacobs of NIH, which is the history of Professor Steve Jacobs, and it gets even confused with the history of this subject itself. He's going to be talking precisely about this interaction between the virus and the host. We will have Professor Lucia Brito, researcher in the neurovirology field of the viral diseases, Professor Carlos Pardo, that has also been working with many spectrums of different diseases manifested by HTLV at the Johns Hopkins University, and has a special contribution here. And Professor Clarice from Fiocruz, Pernambuco, that will talk to us about the conflicts and the diagnosis of this virus. And we'll also have the initiative and the coordination, the general coordination of the program and this event of Cristiane Bressani, Professor Cristiane Bressani, which will participate at the end with some comments within the subjects that we've been discussing. So it's a great pleasure to be here. I thank you for the audience. It's a great opportunity for us to be commenting a very neglected subject, and I think it's an initiative that deserves a great celebration, because this group is acting with the infection with HTLV. So I wanted to begin asking Professor Steve Jacobs, that is, who is from the Institute of a senior investigator of immunology and the division of neuroimmunology of the National Institute of Health of the United States. He will talk about specifically about the interaction of HTLV and the human roast, a long-standing interaction. Professor Stephen, I pass the floor to you.
Thank you. Thank you. So it's a pleasure to be here in this very important, I can't seem to go back now, on our work on HAM-TSP on HTLV1. I'm from the NIH in the United States. We've been working here, since actually the description of the virus. And in fact, on this slide is the description of all the known retroviruses. It's HTLV1 was the first virus actually discovered, actually here at the NIH by Bob Gallo. And we just named them HTLV1 back in 1980, and then subsequently HTLV2. These were first described in patients with leukemia. And these were the days when there was a lot of excitement that viruses cause cancer. So this started the war on cancer was really started with HTLV1. Subsequently, HTLV3 was discovered, and then there are other ones, HTLV4, although rare. And I think you all know that HTLV3 was renamed HIV. So around that time, a lot of us who work on HTLV1 actually moved into the HIV field, but many of us still remain working on HTLV1 because it's association, particularly with neurologic diseases. So what I'd like to do, at least thematically today, is talk about, at least for us here in the United States, research on a rare disease like HAM-TSP, HTLV1 HAM-TSP, can really inform our understanding of at least more common neurologic disorders that we study, that I study here in the United States, and particularly that's multiple sclerosis. So these two diseases they're obviously different, but there's many, many similarities clinically, and I think I don't know, maybe Carlos might discuss this a little bit. And here's a list for you to see the difference. Obviously, in HTLV1, we think we know the etiological agent that's caused by a virus, HTLV. And in MS, we really don't know what causes, although there's a lot more interest in viruses and MS. But unfortunately, even still today in the United States, frankly, most of the patients that I see that come to our clinic at the NIH actually have carried with them a diagnosis of MS for many, many years, till a good neurologist decides to take a test, and we'll hear about how you test actually for this. And in fact says, well, you don't have MS, you have HTLV1 HAM-TSP, so then they get into our clinic. Now, one of the most the fascinating things about HTLV1, it's a virus that infects millions of people throughout the world. We say 10 to 20, but that's probably an underestimate. And you can see here's the global distribution of both HTLV1 and its close cousin HTLV2. And as Augusto said, this is a very old virus. So in fact, you could track the migration of man through the retroviruses they carry. Importantly, the vast majority of individuals, 95% of the people who have this virus, remain as asymptomatic carriers. A small subset go on to develop that leukemia. Another subset go on to develop this chronic progressive neurologic disorders. And now we appreciate there are other inflammatory manifestations associated with HTLV1, like an arthropathy, uveitis, polymyositis, pneumonitis, and so on. So you could see as a model that, in fact, HTLV1 can affect many different organs in the body and cause the disease. Now, in our clinic, we have a very large clinic, and you can see the participant map for the people we see at the NIH really come from all over the globe. And this map really nicely mimics the prevalence of HTLV1. Now, I'm only going to briefly tell you a little bit about some of the clinical manifestations. It's a myelopathy. It's a disease of the spinal cord. Mostly affects females greater than males. And you see all these symptoms that are associated with this myelopathy. And particularly these constellation of symptoms suggest disease process is particularly in the thoracic cord, the thoracic part of the spinal cord. And we'll discuss that later when I talk a little bit about imaging. Now, again, like I said, we probably have the largest clinic in the United States here in North America. And this is the distribution of the patients that we see. We see over 400. Again, I think for parts of the world, this is really perhaps small, but for the United States, this is really quite large. And you can see the distribution all throughout the United States and the states that we get our patients from. A lot of these are migrants, but what's important is we've biobanked many of these samples, both blood, serum, cerebrospinal fluid, saliva, and so on. So, like I said, there's a lot of interest in at least in HTLV1, in HAM-TSP, because we know what the etiologic agent is. It's HTLV1. So the idea, at least we think, at least in the program here, is that if we could understand how a virus is associated with disease like HAM-TSP, can we understand that mechanism and maybe devise treatments in this disorder that we then can apply to a disease like multiple sclerosis, which is predominantly what we study, in which a virus is inspected. In fact, that's actually happened. An anti-TAC, anti-IL-2 receptor was used originally in ham-TSP. It became teclistamab in use in MS. But also part of the cycle is that can treatments in MS be used in ham-TSP? We've done a clinical trial on beta interferon, and now we're currently doing a clinical trial with Aubagio, teriflunomide. So it's a nice use of these patient populations to learn from each other. So really the question becomes, how can a virus that affects millions of people, it's not everybody, but millions of people, 10, 20, probably more millions throughout the world, but how can that virus be associated with disease in a small subset? Is there a virus? Could there be a difference in the virus? The genetics of the individual. In particular, our focus has been on the host immune response. And you could see that this is exactly this multifactorial approach is exactly what you think about a disease like MS. There are environmental factors, genetic factors, and in particular, a number of immunological factors that are associated with MS. And this could even be brought into virtually all of our diseases, particularly autoimmune diseases, in which you need a genetic susceptibility in an individual that through an environmental trigger, here could be a virus that leads to some immune dysregulation. So it's an obviously an important system to study. So one of the observations we made long ago is we think that one of the important aspects of patients with ham-TSP, remember we have these control groups that have the virus but are asymptomatic, is the amount of virus that these people carry, right? So in ham-TSP, they have logs more virus in patients than they do in carriers. So we think this high viral load, in fact, is driving the immune response. And again, a summary of lots and lots of data that we've generated over the years in our ham patients compared to our carriers. Here in the United States, it's actually very hard to find asymptomatic carriers. Why would someone with the virus who's healthy actually be seen by a doctor? We really don't see very many of these. But for the few that we did see, we could clearly show differences between proviral load, RNA, and I'll talk about a lot of these immunological factors that are they're all elevated in patients. And we think these are driving these particular T cells, these CD8 positive cells that we think are immunopathogenic. So we think the induction of an HTLV1 specific T cell response has to do about the virus. The virus is predominantly in CD4 cells, but we also show they're in CD8 cells, and we could show subsets of macrophages can also contain them. This drives RNA expression, drives what we call peptide-loaded MHC, HLA, through technologies we develop. But all of this is driving these antigen-specific CD8 positive HTLV1 responses that we in fact know, at least in particular HLA, is directed to an immunodominant peptide of HTLV1. And the understanding of this process could potentially lead to treatments in a disease. And again, these are just highlighting a number of really very nice reviews. This one's by Charles and Abelardo and Graham on ham-TSP, and I would urge you to look at these. So one of the hallmarks of immunology is really this recognition of T cells and infected cell, any infected cell. And that's through the antigen-specific T cell receptor. It recognizes the CD8 cells through this receptor, has the peptide of the particular virus association with a certain HLA molecule. And we can define these cells by use of what we call a tetramer, all right? It's a technology. I always like to show this because this is a cartoon, but research of a rare disease like ham-TSP actually informs basic immunology, because while I showed you a nice cartoon, this is actually the crystal structure. This was the first T cell antigen specific receptor, human T cell receptor associated with HLA from one of our ham-TSP patients. This was a ham-TSP TCR, and this is the peptide of this HTLV1 protein called TAX, and this is the actual peptide sequence. And this T cell recognizes. So this has been very important in our understanding of immunology. And when we measure that antigen-specific response, we could see it's much higher in patients. These are all HLA-2, but it's much higher in patients with the disease than the carriers. And this is a group, we know the virus is endemic in certain parts of Japan. And I've done a lot of collaborations with my Japanese colleagues particularly in Kagoshima. When we compare the early HLA-A2, they're much higher. A 5% tetramer positive is extraordinarily high. This is fresh out of the blood, right out of the blood. You don't have to culture for any time. You could show that these tetramer reactive cells are right out of blood at this really high rate, 5%, even some individuals as high as 30%. And again, I cannot stress how high this response is. And how high it is even in the blood, it's even higher in the cerebrospinal fluid. So we have access to, when we do spinal taps as part of the workup, we can get cells. And here looking at for the HTLV1 tax-specific cells in the blood, here might be 3%, but in the CSF of this individual, it's up to 16%. And here's just the quantitation of that from 3 different patients. And it seems specific for HTLV1 and HAM-TSP, because here when we look at CMV, we don't see such increases in the CSF. We see a large amount of these antigen-specific cells, again, driven by this high viral load. So here's the viral load in the blood, in the PBMCs, compared to the CSF. And again, you could see it's much, much higher. Here's an example. 70% of these patients' cells in the CSF are infected with HTLV1. So this is a real high viral burden. And work we've done actually with our friends in Brazil, with Marja Puccioni Solar, very good. It was even using this diagnostically in differentiating HAM-TSP from patients who may have, say, for example, in Brazil, who have MS, but are infected with HTLV1. They do not have HAM. And what I'm showing you here is that in the HAM group, again, the proviral load is much higher in the CSF than it is in the blood. All these are really high. And if you just have a non-HAM manifestation, you could see the proviral load is not higher than in the blood. So again, we think this is very specific for HAM-TSP. So this gives us this model where we see antigen-specific cells in the periphery. They enter through the blood-brain barrier. They can enter in this, into the CSF. Okay. Now, of course, do they get into the central nervous system? And do they expand? Is there preferential intrathecal expansion of these antigen-specific cells? And then, of course, what might they be recognizing on a target, particularly on a neuronal target? We have some data for that. And a lot of this is years ago. We were able to help define these antigen-specific cells now, not just in the blood, not in the CSF, but actually in the tissue. So this is an example of a spinal cord biopsy of one of our HAM patients. And when you look in these cells, in this material, you can see loads of inflammatory T cells, CD3, CD4s around the vessels, but lots of these CD8 positive cells. Again, we could show that there's virus in this material, and this virus seems to co-localize with a marker for GFAP, which is a marker of astrocytes. So when we know that cells are infected, T cells are infected, also neuronal astrocytes. So these are potential targets. Work from my group, EJ Matsura, a fellow in my lab, actually had material here. This is from Japan, and using this tetramer staining, this is in autopsy material, looking at spinal cord parenchyma or the meninges, can actually show not only that we found it in the blood, in the CSF, but we actually could find it in the central nervous system tissue, suggesting that these are immunopathogenic. These are bad guys, maybe doing some of the damage. Lastly, I want to focus on some of the work we've also been doing clinically. In particular, we have a large group looking at imaging because this is predominantly a myelopathy, a disease of the spinal cord. There have never been very good quantitative measures of spinal cord atrophy. And we've developed this in HAM-TSP using cross-sectional area. Here's just a number of our publications. And here, when you look at a group of healthy volunteers, that's in blue, this is a normal distribution of the cross-sectional area from C1 to T10, the cervical cord down to the thoracic. Asymptomatic carriers look pretty normal, and our HAM-TSP look much, much less, much thinner. So they have a much thinner spinal cord. An atrophic cord that we can measure clinically. We can show that the thinning of the cord is related to a number of clinical scales, like the first disease duration, the EDSS, and the IPEC, the Brazilian score that we use as functional disability. So obviously, we see increased disability or thinning of the cord is associated with increased disability, increased mobility aid, and a longer disease duration. But more importantly, we can also show that the thinning of the cord, here now we're looking in this direction, the thoracic, is associated with a higher viral load. So again, more virus, you have a thinner cord. And lastly, we can show that this thinning cord was also associated with an increase in frequency of again, the thinning cord. And we could see we have more CD8 positive T cells in the CSF. So having those T cells in there has a very strong clinical consequences, and actually an area that we could clinically target. As I mentioned, I think you'll hear more about disease progression in ham-TSP. Most of the times we see it's a mildly progressive, depends, there's different versions here, I guess. Some are slowly progressive, and some are, we actually do not see a lot of the rapidly progressive. They just don't come to us early enough. We mostly see these mild, less progressive, slowly. And again, this always comes to look a lot like a form of MS that we might see. But we've used our imaging technology. Here's an example of a patient presented at NIH with an 8-year history of weakness in the left leg, dragging both feet, repeated falls, evaluated here 2 years before the first scan. There was little or no progression. This is a slowly progressive. And we measure the cord. Here in blue is the healthy, green is the ham-TSP, and that solid line is the measurement of this one patient. And you can see over 3 years comes with a very thin cord, which does not change. However, we did have a rapidly progressive case. Again, you could just read the case, actually presented to us, 3 years earlier, looks like a pretty normal cord. And over time, we can see the cord beginning to thin, particularly starting in the thoracic region and then going cervically. So again, we think this new technology can use to monitor patients in the course of the disease. So this gives us a model of spinal cord atrophy in ham-TSP, where we see spinal cord neurodegeneration over time. Volume is decreasing, and we see an increase in CD8 positive cells. So again, getting to the idea, in summary, I guess, if we look at the pathogenesis of ham-TSP, the neuroimmunology of what we've shown. Just to summarize, we see pathologically increased CD8 positive T cells in the lesions. Immunologically, we see increased CD8 cells in the periphery, and we've done a lot of work on expansion of these particular CD8 clones, again, higher in ham-TSP than in healthy controls. And clinically, the spinal cord atrophy is associated with the increase in these CD8 positive T cells. So again, just to end, a little bit on how research of a rare disease like HTLV1 ham, here in 20 million people worldwide infected, and how can a virus cause this disease in a subset, can inform our understanding here of a disease like MS, which now is a lot of thought on herpes viruses. It's not quite a retrovirus, which is only 20 million. EBV, all of us are infected with EBV, yet how can this virus cause disease in a subset of infected individuals? So there's still a lot to be done, our learning of ham-TSP to other diseases. And again, I just want to thank all the members of my lab, and it's a large group, our clinical group for getting the patients. And again, all our patients who come to the NIH, actually from all over the world, who participate in our work. So I want to thank you for that. And I'll take any questions. Thank you. Thank you.
Thanks so much, Professor Steve Jacobs. Stephen Jacobson.
Yeah.
Excellent presentation as always. It was great how you showed the complexity level of this disease, this infectious disease. There's no only infectious, but it's very similar to inflammatory diseases, and that shows the complexity of this disease's mechanisms, which makes it so that a lot of people have difficulties managing it, which pushes the disease away from centers, from health centers, and it's calculated by 20 millions, but immunological studies are quite insufficient nowadays, right? It's very, there's an under measurement, and especially with that underdiagnosing, we see a rise in the number of patients. Excellent. So let's move to Lucia Brito, neurophysiologist, head of the Center of Reference for Demyelinating Diseases in the Restauração Hospital and advisor in the Brazilian Ministry of Health. Professor Lucia is going to talk exactly about the neurological manifestations of HTLV infection. Thank you for the invitation, for being part of this webinar. Professor Jacobson already made an excellent presentation on all aspects related to the virus itself. These are my conflicts of interest, and I'm going to talk about, next slide. Okay, so I'm going to begin my presentation with a clinical case, which calls our attention to some neurological aspects, as well as the epidemiological conditions. So this is a young woman who sought out an appointment at 22 years old. She's from Recife, she's non-Caucasian, and at the time, she had presented a progressive complaint of a motor nature in the lower limbs and urinary incontinence. We already saw the progression, and in her history, we saw that the father presented neurological symptoms, and he was positive for symptomatic HTLV. The mother was positive asymptomatic, and the patient was breastfed in her early life. So the patient presented normal clinical examinations, and the neurological examinations showed a motor deficit degree 4 in the lower limbs with an Ashworth scale of G1, so degree 1, hypoparesthesia, clonus feet, spastic paretic gait, and altered sphincters. So due to the epidemiology, she was positive for HTLV through the Western blot test. And when they got to the appointment for the neurological investigation, other investigations for diseases that could mimic it were negative, and they already presented some aspects which were quite evident for urinary dysfunction. So she was defined as a carrier of myelopathy by HTLV. So the diagnosis remained as myelopathy, HTLV myelopathy, and they began treatment at the time, which was methylprednisolone and periodic investigation. Next. So on epidemiology, as this patient focused on some epidemiologic aspects, the older studies called attention to 20 to 40 million infected people worldwide. More current ones focus on 5 to 10 million people infected worldwide, and approximately 4% of these individuals manifest some sort of alteration, especially HTLV myelopathy. This is the distribution on the continents. We clearly see it in Africa, Latin America, and North America. Next slide. So this epidemiology is from 2009, and a little bit after that. This is a study done in Pará for more than 3,000 pregnant women, and 0.3% of the women tested positive for HTLV. At the time, we had 163 patients with HTLV and some evident neurological condition. So 100% of the people there were infected. Next. So the neurological complex of HTLV and myelopathy is predominantly HEMPAT, as it was known. But there were cases which were at the border of the iceberg, like myopathy, polyneuropathy, cognitive deficit, dysautonomia, and motor neuron disease, which could call the attention of neurologists to seek for more emphatic nosology. Next. So the clinical complex, it is important to seek manifestations which could be related to HTLV infection, such as lung alterations, ocular alterations, thyroid, Sjogren's syndrome, as well as those which are more frequently mentioned, like lymphoma and adult T-cell leukemia. So this was already shown by the colleague who preceded me, the image of the virus, its envelope, the double RNA helix, Retroviridae, Orthoviridae subfamily, and Tetraviridea genus. And here's all of the layers of proteins and glycoproteins that compose this virus. So why the neurological involvement, especially for the spinal cord in the thoracic region? Some authors call attention to the low blood flow in that region, which allowed for an increase in molecular adhesion like VCAM, and increased adhesion of CD4 lymphocytes, as well as CD8 in the endothelium, with a higher expression of metaproteinases, especially type 2 and 9, the disruption of the blood-brain barrier, and increased synthesis of pro-inflammatory cytokines, in addition to glial cells, CD4 and CD8 positive. And this makes it so that there's a maintenance of an inflammatory involvement. Next. Which allows the clinical expression of these patients to be of a myelopathy that's predominantly thoracic. So the diagnostic criteria is through the presence of the HTLV1 antibody in serum and sometime in CSF by Western blot, and the exclusion of other mimicking diseases. And you have the definitive diagnosis, probable diagnosis, and definite diagnosis based on the conditions presented and the investigation defining HTLV myelopathy or other neurological diseases associated with it. Next. So faced with the clinical condition, it's important to consider risk factors. So people born in endemic regions for the virus, people who have sexual partners who originate from an endemic area, as it was mentioned in the other presentation. It's more evident in some places. Next. So faced with the clinical and neurological examination presented, we will intend to investigate the patient, and after the conditions is defined, we will try to find the degree of disability, which was already mentioned by our previous colleague. Next slide. So the neurological tests, which considers all of the systems which are more frequently involved, like the pyramidal, cerebellar, sensory, sphincteric, peripheral nerves, and muscles. Next slide. In addition, we have the more rare manifestations and some other involvements like cognitive alterations, cranial nerves, which raise a red flag to be further investigated. Next slide. So faced with the patient, the investigation through MRI, through LCR when necessary, electromyography, especially in cases with peripheral involvement, as well as the biochemical dosages and viral tests which are necessary, in addition to other important tests in the investigation of affected systems. Next slide. So in order to assess disability, initially, many scales were used. Next slide. Including DSS, which was used for MS. You assess the normal examination up until people who may have passed, which is followed by being bedridden. This scale was very thoroughly used, but the most used one is next. The Evandro Chagas Clinical Research Institute scale, which assesses the motor systems. And there's this score which goes from 0 to 29. More involvement in more complex cases. Next slide. Other scales are also used. Still the Evandro Chagas scale. It's interesting to assess the faster and slower progressions when you have the sum of points over the sickness time in years. That way you can calculate and include that patient in that light to severe scale. And how would you expect to find that patient in the beginning of the disease? Several other scales are available for use, varying from service to service, including the Ashworth. This graph was already shown. It shows the mild progression, the slow progression, and the fast progression, which finds patients going quicker to the use of wheelchairs. So I see that this disease really generates a lot of disability in a short time, possibly. Next slide. So this is our experience in the situations that we have found. Next slide. So along 29 years, we've had a segment of 265 patients coming from our own services, forwarded from the hemotherapy center and other services. Next slide. Okay. With a predomination of females, 3.2 to 1. Next. The ages were not that different. Females were a bit older in comparison to the men. Next. And here we see this slide. It's a bit distorted here, but what we can say is that had neuromotor-like Sjogren disease associated with lymphoma, 2 patients with HTLV and hair cell leukemia, patients with polyneuropathy without associated myelopathy, most patients with myelopathy, 248, and HTLV positive, but only asymptomatic 4 cases. Next slide. So based on the casuistry, the asymptomatic patients were reassessed every 6 months, and the oligosymptomatic and symptomatic with a shorter periodicity. The treatment was evaluated, and they conducted rehabilitation. Next slide. So in summary, what were we doing in terms of counseling? We recommended them to refrain from donating blood, organs, milk and sperm. We recommended them to not make shared use of needle syringes and shearing products, and discussing with sexual partners so that preventive measures could be used and prevent sexual transmission. Also avoid breastfeeding. Next slide. So that was my presentation. Sorry for the malformed slide, and thank you for the opportunity. Next slide. And I'm available for your questions. Thank you. Thank you so much, Professor Lucia Brito, for the brilliant presentation.
Aí vocês observam exatamente a complexidade também.
Here you can see the level of complexity of the manifestation spectrum, predominantly medular. This is the neurological manifestation. HTLV is also associated to cancer, a cancer which we will not develop due to time, but the spectrum of inflammatory manifestations, which are not just neurological, but of other systems which could be involved, which present difficulties in determining the boundaries of what is and is not associated. So thank you, Professor. So now let's move to the next panelist, Professor Carlos Pardo. He is the director of the Center of Myelopathies of the Johns Hopkins University in Baltimore. Thank you for your participation. The floor is yours.
Bom dia, buenos días, muchas gracias. Thank you so much for the invitation. My topic is discussing other neurological manifestations of HTLV1 infection. I like to focus in aspects that I have encountered in my practice in neurology, not only in the United States, but also in Colombia, where I'm originally from. And these are aspects of clinical practice that every clinician needs to be aware, particularly when dealing with patients that are in endemic areas like Latin America, the Caribbean, or even in other countries like the United States, where we basically see frequently patients that are coming from many areas of the world or live with people from many other areas of the world. HTLV1 is not only TSP and HAM, as we have seen before. It's extremely important for the clinician that in addition to the concept of HTLV1 associated myelopathy that may evolve in an acute or subacute pattern or may evolve chronically, the clinician need to be aware that there are other conditions like the HTLV1 associated encephalopathy or HTLV1 leukoencephalitis or white matter disease that may be present either in combination with HAM or in isolated forms of a brain white matter involvement. And I'd like to focus part of my presentation to this association. One aspect that is extremely important is, it was pointed out by Dr. Jacobson and Dr. Brito, is the main target of the immunological reaction is very diverse. It's not only the neuronal population, it's the glial population, and obviously many glial cells like oligodendrocytes, as well as astrocytes and other cells in the central nervous system may be a target of that CD8 and T cell mediated injury. I'd like to give you an example of a situation that may be rare, but is a challenge for the clinicians who is evaluating patients with neuroinflammatory disorders. And when I use the term neuroinflammatory disorders, I use the term to refer to patients that show up in our clinical practice with evidence of some inflammatory activity, either in areas of the white matter in the brain, spinal cord, or even the optic nerve. And this is one patient that basically came to our clinic. This is a 54-year-old woman, white woman, who never left the United States, but was married to a person who was living in an endemic area before migrating to the United States. And this patient actually had an initial diagnosis of optic neuritis and an initial diagnosis of multiple sclerosis. And this brings actually the important topic that Dr. Jacobson pointed out before, that sometimes it's extremely difficult to differentiate the two disorders. So this woman presented originally with an optic neuritis that was treated with IV methylprednisolone. At that time, she was diagnosed with multiple sclerosis and optic neuritis, and she was started in one of the medications for multiple sclerosis. Interestingly, this patient discontinued the medication after some side effects, but she continued in many ways relatively healthy until she encountered a problem with a meningitis that after extensive assessment was concluded to be aseptic meningitis. But very soon after that, she started with a lot of problems associated with gait. And this gait disturbance progressed to other type of myelopathic symptoms, including bladder dysfunction. In 2018, actually, she was evaluated more thoroughly, and she was found with evidence of abnormalities in the brain MRI. And actually, this is an interesting observation, because at that moment, obviously, she was evaluated more thoroughly. There was evidence of MRI abnormalities, and HTLV1 assessment in serum and CSF came positive, confirming that the patient has been basically infected by the virus. And the MRI abnormalities were very consistent with a white matter disorder. And interestingly, this patient actually continue a very rapid progression of symptoms, including gait disturbance that clearly outlined the presence of not only spastic paraparesis, myelopathy, but also presence of white matter abnormalities. And this is an interesting point of discussion, because at this moment, obviously, the diagnosis of multiple sclerosis is questionable for this woman, particularly when laboratory assessment demonstrate that there was evidence of an increase in the HTLV1 proviral loss in blood and also in cerebrospinal fluid. So definitely, the clinical profile of this patient brings several topics of discussion. Is number one, this patient likely experienced a neuroinflammatory disorder in which HTLV1 was involved, presented with other clinical features that are not necessarily very common in the classical description of HTLV1, like meningitis or leukoencephalitis, and clearly has evidence of inflammatory activity within the white matter. And this is important because this is exactly one of the topics that I want to discuss, that the clinician in areas that are endemic for HTLV1, when they encounter problems of neuroinflammatory activity in the brain, optic nerve, or spinal cord, needs to be aware about the possibility of presence of HTLV1, and obviously the laboratory assessment need to be initiated. This is an important topic because retroviruses may produce and may present clinically with a spectrum that is extremely similar to multiple sclerosis and demyelinating disease. And this has been pointed out very nicely in a recent review in Neurology clinical practice, in which there is clear evidence that in some subset of cases of HTLV1 infections, there is a spectrum of white matter abnormalities that involve several areas of the brain. I'm going to point out about other type of neurological involvement, and I'm going to talk about the possibility that HTLV1 also may affect the neuromuscular and peripheral nervous system. Particularly, the association of HTLV1 with myositis is an area of interest in areas that are endemic for HTLV1. So the clinician need to be aware that other manifestation of HTLV1 may include peripheral neuropathy, peripheral neuritis, or myositis. And myositis, the only way to demonstrate the presence of myositis is obviously not only demonstration of the virus in blood, but also demonstration by other imaging techniques like MRI of the muscle groups or biopsy of presence of the T cell infiltration in areas of different muscle groups. This is a very nice work, neuropathology and myopathology work that was done in Japan by the group in Japan that has a very large cohort of patients in which there has been a very important demonstration of myopathic changes that are characterized frequently by a very prolonged clinical evolution of symptoms, but by pathology, these patients have a very dramatic infiltration of T cells in areas of the muscle, and frequently are associated with a reduction in the cytochrome C oxidized stains, demonstrating also presence of some mitochondrial abnormalities. The other area that I want to pay attention briefly is the possibility that HTLV1 may produce neuro-ophthalmological abnormalities. And these are classified in two major categories. The first category is when HTLV1 is producing an acute T-cell leukemia lymphoma complex. And occasionally that form of a manifestation that is associated with cancer lymphoma may produce infiltration in the ocular structures, optic nerve structures, producing problems associated with disorders that are basically associated with this leukemia lymphoma. But the other thing that I like to call your attention is the possibility that patients may present with uveitis or optic neuritis. And these are relatively rare disorders, but again, in areas endemic for HTLV1, like in Latin America, the Caribbean, clinicians need to be aware about that possibility because acute or subacute onset of visual loss needs to be evaluated carefully for the presence of uveitis. And after ruling out the potential presence of other neuroimmunological disorders like neuromyelitis optica, multiple sclerosis, it's important to keep in mind that HTLV1 may be associated with optic neuritis. Finally, I like to bring back the topic of demyelinating disease. It's a very important problem for clinicians that are in neuroimmunology, particularly because they are the need to clarify if the demyelinating disease it is or is not associated with HTLV1. And here I will bring back one of the very important papers that was produced in collaboration with NIH, Dr. Jacobson with the Brazilian group. They did a very nice study that demonstrated that technically the only way to differentiate multiple sclerosis from HTLV1 encephalitis is the demonstration in CSF and blood of an increase of the proviral load that is going to demonstrate that the virus is replicating actively and is infiltrating actively the central nervous system. And finally, I like to bring another topic that is very common to all of us that work in infectious disorders in Latin America and in the United States, is in many areas of the world that HIV is still a major public health problem, and HIV is frequently associated with other infections, and one of the infections that is associated with H is HTLV1. And this is a very important topic because the association of HIV with HTLV1 is frequently associated with acceleration of the progression of AIDS and frequently increasing the burden of opportunistic infections. And most importantly, many neurological manifestations like encephalopathy, peripheral neuropathy, and TSP are increased in frequency when HIV is associated with HTLV1. With this, I'd like to conclude my presentation. I am part of the Neuroinfections Emerging in the Americas study that is based in Colombia and Universidad del Valle, and I'd like to bring two of my friends here in Maryland, the good birds like blue jays. Thank you so much.
Muito obrigado, professor.
Thank you so much, Professor Carlos Pardo. Excellent talk. So here we can see the plurality of neurological manifestations of the nervous system, of course, but we've seen recently what took place in Australia, in the Australian Center, pulmonary manifestations in other systems. Professor Carlos Pardo talked about a wide diversity of manifestations and inflammatory diseases like multiple sclerosis and HIV infection. And that is a huge issue. Almost 40 million people infected across the world, and many of them along that belt of where we see the endemic infection of HTLV. So Caribbean, Latin America, Africa, where most of patients who are infected are by HTLV and HIV concomitantly, changing the course of both diseases. So let's continue and call our last panelist, Professor Clarice Nuschenbauer, senior researcher of the Laboratory of Virology in Fiocruz, Pernambuco. She's going to talk about the laboratory diagnosis of HTLV, what we have today, and what are the issues that we have currently for diagnosing HTLV infection. Thank you so much, Augusto. Thank you for the presentation. Good morning, everybody. Thank you for the invitation to be here in this seminar. And thank you to Cristiane Bressani. I just wanted to congratulate Dr. Steve, Dr. Lucia, and Dr. Carlos for their excellent presentations. I'm going to move away from the clinical side and go into diagnosis. So this is my introductory slide. Much of what was said is here. HTLV is a negligenced infection. We see around 2.5 million people infected here in Brazil, more so in the Northeast, Pernambuco, Maranhão, and Bahia states, as well as in Pará. So HTLV is associated to the development of neoplastic diseases, as it was mentioned, neurological disease like HAM, which was already mentioned, as well as to other diseases associated with inflammatory conditions, among many of the ones that were already mentioned. So fibromyalgia, infectious dermatitis, thyroiditis, myositis, and even syphilitis, which this were already reported. HTLV infection have huge impact when associated to other agents like HIV. So there's huge impact when connected to these infections. So right now we have some limitations. There's no specific cure for HTLV or available vaccines. And I'll also talk about the diagnosis tests. But HTLV causes many stigma. Anxiety, depression to their carriers, especially due to it being a relatively unknown virus and the absence of vaccines or treatment. So prevention is the best medicine. So the main forms of transmission, they occur mainly from mothers to their children through breastfeeding, sexual transmission, unprotected sex, sharing syringes and needles, and blood transfusion and organ transplant. In Brazil, this screening has become mandatory since 1993 and in 2009, respectively. Next slide.
So what would be the importance of test for HTLV, so it's fundamental because it's going to block the vertical transmission, which is the most prevalent one, together with sexual. So it's important to have this diagnosis. So it's important to have this precocious diagnosis so that we can counsel this woman not to breastfeed, so that we don't have this transmission from a pregnant woman to her son. So it's important, as I said, to counsel the infected, resulting in a better life quality, the clinical conduction, and the thorough care of the host. And it's important to understand the real prevalence of the infection. In many states of our country, you don't know if it's prevalent with pregnant. So who should test for HTLV? That's the first slide, the first question. So blood donors, organ donors, from people from the family, sexual partners, children exposed to HTLV, individuals with problems with the bowel, neurogenical issues. So continuing, who should test for HTLV? Differential diagnosis, it's important to differentiate from other myelopathies. Individuals with blood transmission or sexual infections, patients infected by Mycobacterium tuberculosis, patients infected by Strongyloides stercoralis, patients with leukemia or lymphoma, and cases of explosion of material of drug users. Next one. How to carry on the diagnosis for HTLV? Currently, it's done in two stages. The first one in the triage test, and the second test, confirmation test for discriminatory of viral types. The type 1 is the most prevalent, but with two less pathogenics. But we've seen in many jobs the association with HTLV and some neurological manifestations. But it's important to know what type of virus is for that patient. The next one, please. So as a triage test, the most used are the ELISA, the immunozymatic research, or the CLIA, and we use blood banks as well with chemiluminescence. So we have with this test the genetic code, and we'll understand other proteins. Those are tests that have high sensibility and variable specificity, with results that might be fake positives or inconclusive, which will elevate the cost with diagnosis. And Dr. Daly also, she's watching us here, and she knows about that. The fact that this could be an alternative to decrease the cost in this pool of samples. And this test do not differentiate the viral type, so it's needed to have a confirmation test. Next. So the second stage, the checking tests, we can divide it in serologicals and moleculars. We have the Western blot, LIA. So we detect antibodies with different proteins of HTLV, such as the PTN, a recognition of HTLV1 and HTLV2, with the RPG46, which is an envelope protein with epitope. And with the serological and molecular tests, they have a high cost. Just to show you here the interpretation of the washing block, we have to the right of microcelluloses, we sensibilized with the virus for type 1 and for type 2, and here we see a pattern, a negative pattern, which is HTLV. We don't understand if it's 1 or 2. And we identify for HTLV1 and 2 as well. Next one, please. So continuing the confirmatory tests, talking about them in terms of moleculars, it's detected on the DNA proviral that is integrated in the genome of the target cell of the host. So we can, with high specificity, and we can increase sensibility because this DNA is probably integrated to the genome. So as I said, high specificity and sensibility. The main techniques used PCR, the real-time PCR or LAMP. And these techniques are integrated with the qualitative diagnosis with the differentiation of the viral type, as well as the quantity of the load of proviral on the HTLV. And we will be doing the monitoring of the patient and the evolution of the patient, and also the diagnosis, the differential diagnosis for other myelopathies for the viral charge, the viral load on the VCR. On the PCR, I'm sorry. They are, the protocols are in-house, so there's an absence of validation, but they are very important because they contribute on the cases where the WB are inconclusive and in children below 18 months with a precocious diagnosis. So here we have a fluxogram of a confirmatory diagnosis with serologic tests. So just to show you here that we begin with a blood sample when we do a triage by ELISA or luminescence. If we have indeterminate or inconclusive result, or as well as a reactant, we can discard them or send it through SIM to confirmation, serological confirmation through LIA or WB. And if the result is still inconclusive or indeterminated, we recommend the molecular test to clarify the diagnosis. Next one. In results, we have inconclusive results of Western blot. We have the phase of seroconversion. The immunologic window is around 90 days, and it can be caused by the HTLVs distinct strains that can be found in the fabrication of the test. The presence of viral particles, there are defective viral mutations and low charge of proviral, mainly HTLV2. Next, please. So there's a fluxogram of the diagnosis. We see the fluxogram that is determined by the health ministry. You use the molecular test as the confirmatory test that follows, as well as the serological test, the triage using ELISA or chemiluminescence. If it's reactant or indeterminated, it goes through the next stage of diagnosis using confirmation, molecular confirmation, and its variations. And as well, it's important to understand that if the result is with the DNA, a proviral DNA that is not detected, we recommend the utilization of a serological test to exclude the false negative. And then you can use LIA or Western blot. This last week, an infectologist called me with a case with a patient that found HTLV positive via a blood bank. This patient made in a private laboratory another triage test and PCR, and the second triage test also responded as reactant for HTLV, but it was not the DNA, the proviral DNA was not detected. So he talked to me and we recommended him to follow with the confirmatory test, serological one, to close the diagnosis for this patient. Next one. So some challenges that we have regarding HTLV, the lack of understanding from the population and some of health professionals as well around the virus and associated diseases. We have a big support from Ministry of Health, and I speak on behalf of Dr. Fabio and Dr. Angelica in divulging campaigns stimulating the professional capacitation, which is very important for counseling and clinical follow-up to be adequate. But we need more investment in research. Currently, we don't have a quick test available, but the good news is that we have 3 quick tests being developed in Brazil, 2 in validation phase, and 1 in development made by our group here in Fiocruz, Pernambuco. And we have another test, which is not in Brazil, but is a quick test being developed in Japan. So as far as the implementation of public policies for routine in prenatal, we are advancing a lot in Brazil. Some isolated states have that, such as Bahia and Mato Grosso do Sul. So this routine prenatal testing, besides that, we are testing other tests with other vulnerable populations. And to close, I'm already there. I think I went over my time, but I'm finishing here. It's just to final slide to talk a little bit about our motivation as researchers, health ministry, and virus hosts, that we are allowing the proper care for the people that live with PV-HTLV. And what motivates us are the ones that have the virus. We took this picture in a symposium, international symposium, that went on here in Brazil, and I had the honor to be organizing it. It happened in October in Paraíba, and it's because of them, for them, that we are wearing their shirt, really focusing on that, being on the same page, with integral support to them. So thank you very much. Thank you. And I want to leave you my email here and our channel here in Instagram, HTLV Brazil, together with the Global Health Network in the organization of this webinar. Thank you very much, and I'm available for answers. Thank you very much, Professor Clarice, for this excellent presentation. We have some diagnosis problems. Some of them are in-house, but there is a fluxogram, a diagnosis flux that is very efficient, and it's very able to be applied in an universal way. So it doesn't justify that there is a programmation that can be done to higher populations. I wanted to ask Professor Cristiane Bressani, senior researcher for virology and experimental therapy, to compose the table for the discussion of the questions. We have many questions, so I wanted to say to the table that we have many questions, and some of them I'm going to address. Professor Cristiane, how are you? It's a pleasure. Professor, please, I wanted to talk a little bit about Dr. Augusto is going to organize the questions, and I'm going to talk a little bit about the work that we've been doing, the networking, which led us to create this webinar. First of all, I want to ask the panelists that approved the idea of being here and talking to us. So I'm going to present to you a research club of neuroimmunology and neuroinfections. This club is being proposed and supported by the Global Health Network. And I want to talk a little bit about it quickly. Everything everything started to happen with, just a second. I'm sorry, there was a question here. So this research came out in the pandemic, where we investigated the association of AVC with the SARS-CoV-2 association. And then, next, please. So it's a case in Brazil, nationwide, a protocol that had their support from Fiocruz, but faced many problems because we were in the pandemic. Next one, please. So, due to the pandemic, we were in a situation of social distance, health professionals with an overload of work, overburdened, reduction on the health workforce due to infection, interruptions in support services, and closing of research institutions, reductions, delays, and increasing prices of health supplies, uncertainties regarding parameters, and also how to predict the sample size. Next. And in this next one, in this context of chaotic context, we were able to manage, with the help of Lucia Brito with the Neurology Brazilian Academy, we were able to get in touch with many neurologists so that they could join us. 12 professionals in specialized centers, all of them from SUS, and they all agreed on the challenge. And with that, we were able to have a partnership in many places of the country with the main departments that were working with this process, although they were with with many challenges because of the pandemic. So we were able to create a partnership with hospitals and laboratories from SUS using this health system, this structured health system. SUS is the public health system in Brazil. And we were able to get a team together. They were very motivated. The health professionals, in fact, are to be congratulated because they show their services, they show their effort and how motivated they were, and simply helping scientifically on how to battle this virus. Next one, please. This is a map so that you have a notion of the places where we were able to reach. So north and northeast, Midwest, southeast, and south. The last service was cut out, which was in Santa Catarina. You can go to the next one, please. And here, I wanted to thank all the teams. These presentations will be available for you. I don't have the proper time to name everyone here, but I wanted to thank especially those that are present here: Lucia Brito, Dr. Clarice, the coordinator, together with me, the co-coordinator in this project. This project was financed by the Osvaldo Cruz Financial through an edital, a national bid, and it was coordinated by Fiocruz Pernambuco, by us. I want to thank João Felipe, Jurandir Magalhães, that's also present here. If I left someone out, please forgive me. You can go to the next one, Marta Rodrigues as well. And after all that went through, we were able to get all the samples through a lot of blood and sweat because of the love that we have for research. So we were able to continue this interaction, this network, And many of these teams are now putting together a group to discuss new analysis with these results. And with the Global Health Network support and this partnership with Fiocruz, we are launching today our own website. Now, our group of research or research club. So if you're interested, this is the website. It will be also posted in the chat, and you can access through the QR code. We have health students. We want to invite them from post-graduation to discuss their products. Okay, thank you very much. Thank you, Dr. Carlos Brito, Augusto Penalva. Thank you very much. And the Global Health Network team.
Muito obrigado, professora Cristiane Bressani. Excelentes comentários.
Thank you, Cristiane Bressani.
Parabéns. Bom, vamos dar seguimento com as questões.
So let's go on with the questions. We have many questions here. I want to put them together because many are convergent. Some questions are very different, so I'll go from them, and then we go to the questions that are similar. Lida Osorio has a question that is very interesting. I think she's a specialist for infection on HIV because of her question. I'm sorry, not her, Maria Cristina Ribeiro. Obesity is a risk factor for for RUM. I believe it is because the metabolic disease is a subject as a pro-inflammatory subject. So we've been discussing pro-inflammatory issues such as a big problem for chronic infections causing the central nervous system and cardiovascular systems, the HIV that are obese continue to evolve in terms of chronic process inflammation. So if she asks if obesity is related to the risk factor for RUM, I would say that there isn't this date precise of obesity being a factor for RUM, but what we see is for HTLV progress, we see that inflammation diseases can happen. We see this in the Aborigines from Australia, especially with diabetes, I'm sorry. So we've seen the pulmonary manifestation, and diabetes was in fact a risk factor. But for the neurological disease, we don't see this factor. If the other colleagues want to comment, Professor Steven or Lucia Brito or Carlos Pardo, if you want to comment on this data. Well, I think I can comment. When we talk about the desmyelinizants diseases, we've seen many studies showing that obesity is a risk factor, among others. But for my knowledge, I don't recall any work being done as seen here many times. It's a neglected disease. So if we're going to really look at it, and when compared to other diseases, the papers, the articles, the works are very reduced in numbers, and the search for other factors that can contribute for these infection, environmental factors, daily habits. But for some diseases, yes, since it's an inflammatory disease, as you said, it's possible. But for my knowledge, I don't recall any researches on that manner, on that subject. Okay, great. Let's go to the comment now from Lida Osorio. She asks about the clinical trials for HTLV. Electromicrography could be a mark, Well, it's a central disease from the nervous central. So this is a mark for peripheral diseases. As Professor Pardo said, they can be frequent, but the disease is a myological disease, and it's chronical. But in the clinical evaluation, we're talking about the main marks, and the clinical tests are the most important. The Ozami scale, the Fiocruz scale, the EPAC that we use a lot. And we have some inflammation marks like neptarine, the proliferation, lymphocytary proliferation, and the viral load. But of course that this is much more within the research trials as an efficient therapeutic mark. Professor, anybody would like to comment on that? Professor Steven? First I want to comment here. Of course that the way that we address the complementary tests will depend on the clinic that the patient goes to. So if I have a patient with a certain evaluation, with a problem with the nervous central system, without any changes on the peripheric, the electromyography will not be part of the arsenal because we know that there is a cost. So we'll go to images, the marks on differential diagnosis with other conditions. But if I have a peripheral disease, whether it is neuroperipheric or muscular, I will address it to a electromyography, but on its own, it's not going to define the process, the answer for the process as being the HTLV, but not necessarily will say that it is related to the virus, and it will remain, the research will remain on the search for the etiology. Thank you.
I just might add that I think the goal is, in a therapeutic setting, what is ultimately the goal of the therapy? Okay, so for example, we know in HIV, it's been very important to reduce the amount of virus to negligible. And I think that's important. We don't have that yet for HTLV. We think viral loads are very important, right? So all things considered, I'd rather have a low viral load than a high viral load for long periods of time. These are chronic diseases. So how long would you have to suppress that viral, the amount of proviral DNA for how long? And that's some of the markers that we actually do in our trials. So if our trial goes for, say, a year or two, we would like to keep that virus fairly low. Now, I know, for example, the mogalizumab trial in Japan, I think, has just recently not succeeded. It has actually reduced viral load, but it did not change much disability. So I did not think I actually know it did not get approval from the Japanese PMDA. So again, viral load is just one surrogate. I tried to show you, we do have some MRI surrogates now, right? We could quantify spinal cord atrophy. But I think the reality is, once you have a thin spinal cord, what's the chance of that ever remyelinating? Right? So halting progression is just as important as remyelination, and the idea that it's the same logic we have in MS therapies as well. So it's very challenging on chronic diseases. And Carlos would say something, I'm sure.
So, Steve, actually, I don't want to extend on the discussion, but I'd like to ask you, who has been at the center of the clinical trials at NIH. So what is the future that we have for clinical trials for HTLV1, particularly for the neurological disease? It is the control of the T cell reaction, or is the antiviral effect? So what is in the future?
So, I think we're learning from other diseases. It may be combinatorial. Maybe you need both. Maybe you have to reduce the immune response in addition to trying to reduce the virus. Okay, so we're coming from it from two different aspects. Frankly, there are really not good antiviral medications right now. We have been trying. Nothing has actually been made for HTLV1. A lot of the drugs are HIV repurposing type drugs. They have some effect in vitro, but they not have much drug effect in the patient. We are looking if we could identify these immunopathogenic T cells. That's an area of therapy as well, trying to reduce that inflammation. And as you know, you all try clinically, your first round of thought is probably, high dose methylprednisone or something like that, right? You want to dampen the immune response. In fact, it does have short-term gains, but not for long-term. So that may be very difficult. So I think this is a very difficult disease to think about. But I think for the patient, lack of progression is actually very important for that patient, right? You may never cure the disease, but having them just slow down and stay where they are may be actually very beneficial for them. Versus the remyelinating and the stem cells and all that type of thing. I saw there was one discussion in the chat about vaccines, right? We saw that. And I think, and I know that's been purported because we're obviously in EBV, we're thinking about vaccines as well. But the question is, how do you vaccinate? What population would you vaccinate? Would you think of it as a prophylactic? And maybe you could only do it in something like Brazil or Japan, or these highly endemic areas, because you can never do that in the United States. You can never do a prophylactic vaccine. How many people would you have to vaccinate to protect how many people from infection? I probably prefer more of a therapeutic vaccine, right? Like we have for shingles. But the viruses, these are very different viruses. This is a very chronic type of thing. There's not much expression of this virus. It goes from cell to cell, unlike some of the herpes viruses. So these are really a lot of challenges that we have to think about. I mean, on a personal note, I don't think I will ever be around to see the effect of a prophylactic vaccine for HTLV. It's just, it wouldn't happen for me, But these are very good questions. I would probably go for small molecule inhibitors if I had to make my bet. Try to stop that virus from coming out. That's kind of the way I like to do it, or dampen the immune response. So those are the type of things. And I think clinically, you all very well know how to monitor patients clinically. I don't think that's the problem. Okay, I think you have good tools for that. Okay. We've learned from the MS trials, in fact. So we're very good at doing MS trials. I mean, that we're extremely good at. All over the world, we're very good at outcome measures and powering studies and so on. But for these chronic diseases, and I actually know a lot more of the companies are thinking about that, actually, to getting into these progressive neurodegenerative type diseases. So, if there's a market for them, the money's there, and the research follows. So I'm not that, I'm not trying to be pessimistic, but I'm just trying to be realistic. Okay. That's what I believe.
Professor Pardo, gostaria de comentar?
Professor Fabio, would you like to comment?
No, it's okay. Clarice is raising her hand.
Obrigada, Professor Carlos.
Thank you, Professor
Dr.
Carlos.
Steven,
Dr. Steven,
existe algum clinical trial
is there any
para
clinical trial
receptor de
for
checkpoint imunológico,
receptors of immunological
T3,
checkpoints like
PD1,
T3 or PD1?
em relação a esses processos de exaustão celular
In
que a
terms
gente
of
sabe que
these
ocorre
cellular
em
exhaustion
infecções
processes that we know that take
virais
place
crônicas,
in
né,
chronic
o
viral
HTLV, a
infections
gente
like
vê alguns
HTLV.
artigos publicados
We
em
see some
HIV
papers
e
published on
hepatites,
HIV or
existe
hepatitis,
algum clinical
but
trial
is there any
para
clinical trial
investigação desses
for,
receptores,
well,
né, desses
investigating
inibidores de
these
checkpoint
receptors and
imunológico para HTLV?
immunological
A gente está
checkpoint
com
inhibitors for
pequeno projeto
HTLV?
de uma mestranda
We have a small
que
project
está
from a
começando a
master
avaliar
student.
isso, mas
We're starting to
existe
assess
alguma
that, but is there
coisa
anything
que o
like
senhor
that
tenha
already that you were aware of?
So on the clinical, so we've actually done a trial on pembrolizumab, anti-PD-1, in PML, progressive multifocal leukoencephalopathy. Okay. And right next door to me, we do that trial. Those are not easy trials, frankly, actually. There's nothing obvious for HTLV1, but we do know, we've published many times that, in fact, there's high levels of PD-1 on these CD8 cells. You know, there's a number of checkpoint inhibitors. There's really a dysregulation. So it's not unreasonable, but again, getting the patient populations high enough. And again, how long would you have to treat? You know, one of the big PML is a pretty acute disease, frankly. I'm sure Carlos knows these patients well. You have very strong outcome measures. I mean, it's a very bad disease. You'd look at a chronic disease like HTLV, where you may have to treat for years and years. That may be challenging, actually, for a checkpoint inhibitor, considering you don't want to dampen the entire immune response, right? That's why I like to target. So if we think we have pathogenic T cells specifically, can we knock those out? And again, for how long? And those are some ideas that we're thinking about. I have a question for Clarice. So one of the other things we're very interested in, as you know, I think we spoke about this, is the seroindeterminants, those indeterminate Western blots that you see. We see so much of that. And in fact, we're doing work in Peru and even some work in Brazil, I know. These Western blot patterns are all over the world. And we still don't know what that means. And I think, and remember, your algorithm for testing is they probably have to be originally ELISA positive to even get tested, correct? Right? We've been testing people who we don't even care about their ELISA status. There is a lot of seroindeterminants out there. Even in Bethesda, Maryland, you know, it's not in the Peru, in the Amazon, you know, basin or indigenous tribes. It's just in right by in our bloodline.
Yeah, well, what's established here in Brazil is that we continue this chemoluminescence or ELISA test, and in a determined reagent result, both would go to the confirmatory test. Between the Western blot and LIA, LIA is better. It tends to be seen as better. It performs better than Western blot for avoiding that high number of inconclusiveness that they usually see. It may be good to either repeat a LIA because it uses synthetic recombinant.
Right, yeah.
Western blot, it only uses 2 recombinant proteins, one for HTLV1 and another for U2. And the other antigens are for total. And LIA doesn't have that. So it's better in that sense. It performs better due to these epitopes, which are synthetic recombinants. In addition, okay.
Yeah, so I agree that it's better to determine HTLV1 from HTLV2, but I'm saying the indeterminate itself on the Western blot actually is maybe telling us something, actually, right? That in fact, having all those other antigens, in fact, may be very important. Particularly, we're finding it very, very strong if we look at African Americans versus Caucasian Americans. We find maybe 10% of African Americans may have these, and in fact, even higher in patients, African Americans with MS than Caucasian Americans with.
Yes, the immune response is been influencing the antibody response, should be influencing these different results of the indeterminate ones. That's quite strong. There are individuals that don't respond to all of these antigens, like text only, and so all of that is influencing it. So those indeterminate results, have you been doing any molecular tests for them?
Yeah, and virtually all of the indeterminants are PCR negative. So I would agree, they're not shedding virus. But it still suggests to me they could have been exposed to HTLV1 somewhere. Mother to child transmission for generations. You know, this is, Augusto told us it's a very old virus. This has been on the planet for millions of years, particularly in these different indigenous populations, you know, that through the migration of man. So the idea then would be there may be much more of exposure than we ever thought. Now, what's the clinical significance of that? That becomes a different question. So we have had patients who've had some neurological, so Carlos, for example, they come with paresthesias and pain, you know, things like that, but they're always seronegative, but some are indeterminate. And we see a lot of indeterminate from mothers or family members who are HTLV1 positive. So we could track that somehow. Both we did this in a breastfeeding study from a transmission study and a transfusion study we did in Jamaica. Right. So if you had HTLV1, you were more likely, if you were seroindeterminate, you came from a mom who might have been HTLV1 positive. Again, suggesting transmission, although I don't know the clinical. The point is, what we have in the United States, and what I've said to the FDA here, when I see a seroindeterminate, would you want that blood transfused into you? Would you want that in a transfusion? Correct. That's what I said. Right? Now, and you might get it. Remember, you could be seroindeterminate and ELISA negative even. But again, if you don't test by ELISA, you may get that blood. And I would say, I do not want that blood. I do not want my child. I do not want my mom to get that blood. For whatever the reason, I just don't want that. You know?
Exactly, for sure. We've been doing populational basis studies in Recife, the capital of Pernambuco state, the Northeast, evaluating the prevalence of HTLV in the general population, not one specific group. We did the screening of 2,000 participants. Cristiane is also part of it. And we've already observed the ELISA results. We've seen a pattern of agglomeration in some locations that concentrate positive cases for ELISA reagency and indeterminates. So they are in that same general surrounding. So we still have to assess the confirmatory test. We are at that stage right now. And after that confirmation, we will then include the intrafamilial investigation. But we see from the screening that there is a pattern of agglomeration, aggregation rather. It moves from generation to generation.
What was the frequency of the 2,000?
I think 2,000 participants, we've had 240 positives and indeterminates.
Right.
In the screening.
10%. We always see 10%. I'm telling you, this 10% number is very universal. There may be a background.
Yes, it will move to confirmatory still.
It'll be less.
I'll get back to you.
It'll be less than 10%, but the indeterminate will add that. I could show you Western blots that is just amazing from the Shipibo tribes in Peru that we're doing with Eduardo Guttuso. And again, the Shipibo come to Lima to work or something, right? It's amazing. About 40% are strongly indeterminate. And again, that says to me, this is not just that. It's not. I mean, there's some suggestion it was by malaria. Remember falciparum? It was a cross-reactivity with malaria. We don't have malaria in Bethesda, Maryland. Okay, that I know. Maybe in Baltimore, they have more malaria than we do. But
we do have malaria in Baltimore.
you probably do have a little, but not a lot. I mean, you don't have 10% malaria.
Muitos
That's for sure.
fatores associados, né?
Yes,
Além
many
além
associated
do teste em
factors,
si,
right?
né?
That's
Just
right.
in addition to the
As
test
cepas
itself.
utilizadas no
Right.
teste, mas também dessas origens
But
diferentes.
also
But
the-
you're confounded, particularly in Brazil, with the ethnicities. You have a very ethnically diverse population
Sim,
throughout all of Brazil, I guess, right? You know, so I know you've got many admixtures and so on. So there's going to be a lot of complexities. But my suggestion is to this group and maybe to the audience is the idea there may be more HTLV out there than we think. You know, I think that may be a theme that we're getting, whether
I
it's the
think so too.
clinical, you know, the clinical iceberg, where the clinical is just the top of the iceberg, but I think it's the virological iceberg as well. There may be much more virus out there
sim, sim.
than we ever thought that we carry because it's transmitted,
Concordo,
right? If it
concordo. E a
doesn't
gente
cause
tem
I
disease.
agree.
também
I agree.
de
Yeah.
And we also
Yeah.
have the intention
desenvolver todo o
of
sequenciamento aqui, a sequência
doing
circulante, né?
sequencing for
A
these
gente não
circulating
tem
strains.
esses dados
Yeah.
mais
We don't
aqui,
still have that data here
em
yet.
Pernambuco a gente não
Right.
tem.
In Pernambuco, we
A gente
don't
vai fazer aí
yet haven't.
dessa,
We have to
dessa
conduct
análise desse
those
inquérito epidemiológico,
analysis,
desses
this epidemiological
240 e
analysis
poucos
Yeah.
of these
domicílios, né, que a gente tem
240
esses casos aí,
locations where we've seen these cases.
de 2.000 participantes. A gente vai também
Among
fazer
2,000
parte do
participants, we'll also
sequenciamento
do sequencing,
do vírus também e ver
the
o genoma
viral
completo do
viral
vírus. Então, a
sequencing
gente
and
vai
see the whole
tentar
genome. So
investigar
I'm going to try to
tudo isso aí, né, que a
investigate
gente
all
estava
of that.
comentando agora.
Yeah, whole genome would be very important, not just envelope. I think you now with the new technologies, we're sequencing with, in fact, with what Christina was telling us about SAR and COVID-2. There is that technology has really ramped up for all of our ability to really move a lot quicker and in much bigger space to look at more viruses and complete virions and things like that. So I agree.
Isso
Great.
aí. Obrigada, Dr. Steven.
Obrigado.
Obrigado. Professor
Thank
Carlos
you.
Pardo,
So
se você
Professor
tiver que sair,
Carlos
se você
Pardo,
fazer algum
I
comentário,
think you have to leave, right? If you want to make any
precisa
comment.
sair.
No, I appreciate very much all the comments, and I'd like to add a brief editorial comment to Steve's remarks about those uncertain Western blot findings in Latin America. I think that probably that also reflects one of the slides that you showed, that probably HTLV1 populate the Americas very early. In the evolution of our population. And I think that this is quite fascinating for retroviruses, because actually retroviruses are embedded in our DNA already after millions of years. So that probably is some interesting topic of research for the future. Thank you so much for the invitation.
9% of the human genome is retroviral.
Excelente. Eu convido o professor para ficar. Se eu tiver que sair, a gente compreende. Acabou nosso tempo.
So we have gone much over time.
Mas eu acho que valeu muito a pena pelo
I think it was worthwhile. The content was excellent.
Exatamente, tem questionamento
Thank you.
interessante sobre o HTLV3 e 4.
There's an interesting question about HTLV3 and 4.
O HTLV1 foi o primeiro vírus, depois veio o HTLV2. E o HTLV3 e 4
HTLV3 and 4
very rare. 2 people.
Exatamente, bem raro na região
yes, it's quite rare, especially on the coast. These are ancestral viruses, which are even more adapted. The HTLV, HTLV2 must have 200,000. These viruses are ancestral and much more adapted to cellular biology. There are many questions concerning the vaccine. Just a comment on Professor Stephen's comment. So art imitates life, right? The biggest issue in vaccines for retrovirus is that it doesn't clarify viruses very well. It doesn't become clear in infections as other respiratory or arboviruses, which you have this natural phenomenon and you reproduce it with proper antigens. So natural history, nobody has been contaminated with a clear infection. So it's hard for you to have a prophylactic vaccine in that way. There's a therapeutic vaccine being developed for HBV, the infected cell, which sensibilizes CD8 against it. It's being developed for patients who are already infected or who are developing it. So there are many other questions for that. So clinical markers being developed. I strongly recommend for treatment that we write up a guideline for neurological and clinical practice. Professor Stephen was a part of it. We were as well, with other colleagues from Australia, Japan, the UK. It was reviewed last year. So this guideline talks about treatment, including the clinical evolution of these patients, fast, slow, non-progressive, and there you'll be able to read more on the disease and how it is clinically addressed. So on prevention, horizontal transmission, same as other viruses, and prenatal is essential. Japan was able to pretty much abolish that, and it dropped to less than 4% in 2 generations by controlling prenatal, because it's quite silent. So people don't know that they are transmitting it, as Professor Stephen was saying. There's probably a lot more because there are more people contaminated than we believe, than we know, rather.
Yeah.
The World Health Organization and the Pan American Health Organization have been developing several documents on prevention, contamination prevention. I strongly recommend that you go on the PAHO and WHO websites. There are many documents there that you can read on prevention measures for breastfeeding and, well, a lot of the questions which were put forth, maybe the most important ones concerning clinical detection, risk factors, transmission, therapeutic approaches that we can address. The other questions, we're going to try to answer one by one later. Thank you so much, Isatu Sa. He sent many questions and many comments. Quite active participation. Thank you so much. And I just wanted to thank the Global Health Network, Fiocruz, Professor Cristiani for the organization, Professor Lucia Brito, a legend on HTLV infection. Thank you, Dr. Stephen. And so I'll pass the floor to Professor Cristiani, to whoever wants to wrap up. Thank you, Dr. Augusto. I want to ask Dr. Stephen a question. We have a few studies to investigate the transmission in the transgenerational characteristics of infection. Those that are positive in the tests, and we will investigate the previous generation and the posterior generation, so mothers and children.
Very good.
So my question is, so the inconclusive ones, couldn't they be an intermediation between the endogenous virus and the pathogenic retroviruses, the ones that are actually found in the molecular tests?
Sure. I mean, they could be parts of the virus. That's correct, right? But I still think it suggests, because of its cross-reactivity with HTLV1, that indeed it's probably HTLV1 related. Okay. But you're right. It may not be a full virion. But again, we happen to see a lot more of those with people with some of these neurologic diseases. That's why they come to us, right? So in my clinic, the only reason a patient comes to me is they have something wrong, right? You have the ability to go out and look at the asymptomatics. That is something you could do that I cannot, okay? So, or family members, because again, I mean, we have a large clinic, but it's relatively small compared to what I think you or Japan can show, or Africa clearly could do that. But you're right, it could still be parts of the virus, but I still think it's there. I don't think it's endogenous, that's for sure. Okay, it's not the ERV-K group, the ERV-W group. There's lots of human endogenous retrovirus. These are not part of this. We are working on another way because, again, my research is involved in the immune response. So we can, in fact, induce T cell responses from these patients to HTLV1 tax, if they're the right thing. So that tells me something. So that's at least they have a T cell memory, right, of something they may have saw and cleared the virus. That was great, right? They may have seen the virus early on in life, cleared the virus, and this is the remnant, right? They have an antibody, a B cell clone that's making some antibody that we could pick up. Again, that's perfectly reasonable. But the point is, it's about exposure. That's what, and I think your family, your generation, your multi-generational approach is going to be very important. Except I'm going to tell again to Clarice, if you're only relying on those that are ELISA positive, you may lose a lot. And of course, now you come to expense. How do you then look at everybody, right? I mean, I could do Western blots on everybody, but that's a lot of money, right? If you,
O custo é altíssimo, né?
Yeah, the cost is extremely high.
yeah. So maybe you'd have to do it on subsets, but it's very important to rely on the ELISA only. We may lose. That's why I said, when I looked at my African Americans, they were all ELISA negative. That was the point. These are blood bank donors.
Incrível.
Yeah.
Incrível, né?
I thank you. I would like to comment about the biobanks and the studies on hair diseases that you present about it also, and say I would like to say you that we are studying in this way too here in Recife, and it was very good to hear these issues from you. And I think you could talk about all these things after. Thank you.
Thank you, Cristiane. I'm afraid we need to close.
Yeah,
we are very
right.
late, and I will ask to Cristiane to close in 2 words, please. Thank you very much for all. Thank you, Stephen.
Thank you. I'm going to say
Thank
goodbye.
you all.
Thank you, Vera. Bye-bye.
Thank you. Bye-bye.
Bye bye. Thank you all.
Thank you to everyone. Thank you.